Now over to Peter Rimington to talk to us about innovation in an era of evidence-based medicine. Peter is a consultant in Eastbourne.
Thank you very much, Frank, again for the slightly poisoned chalice, but I must admit it's been a really interesting topic to think about, ask colleagues about, and reflect generally. I suppose the first question you want to ask yourself is, what is an innovation in this day and age? If you look it up on the famous Google, you get all those words in the thesaurus as to what you can call it. So I decided the one to pick and to look for in discussing this was a revolution. I liked upheaval, but I thought revolution was the best one. And the next question you ask yourself, well, is an innovation, is it an invention? Do you have to invent something to have an innovation? The thing is, to be called an invention, all you have to do is have an idea that needs to be proven as workable. To call something an innovation, you have to take that and you have to make it replicable. It has to be cost efficient and it has to satisfy a specific need. It's different. So an innovation in its full extent is a process. It's not a snap. It is a process which translates your idea or your invention into a goods or a service, whichever one you're looking at, that creates value for which your customer will pay. And that's what businesses will call it. But we're not in quite the same business. So what do? We want to create value for our patient. So the first thing you must ask yourself when somebody says, I've had a fantastic innovative idea is, oh yeah, who benefits? Is this innovation for the benefit of our patients or somebody else? So innovations in medicine must improve patient care and outcomes. There are two types of innovations. One is the evolutionary innovation, which is mostly what we're involved with, that are many small incremental advances in technology and processes, and I think that is the one that you see most often in medicine. There have been lots of talks in this week, John Kelly, especially Indy Gill, talking about the search for zero defect, incremental gains. The Sky Cycle team, they went for this. It's not a massive change that will get you to win the Tour de France. It's shaving 0.5 grams off your bike. It's shaving 100 grams off your weight. It's making your clothes slightly more slippery. It's a whole contribution of lots of little things that get you to an improvement, and those are innovations. And then you have a revolutionary innovation which is disruptive and it's completely new. So it's like going from a horse-drawn cart to an internal combustion engine. The next one we're going to get is the anti-gravity drive. And those are revolutionary innovations. They're not really something that you're going to see a lot in medicine anymore, I don't think. Look how we went from open surgery to laparoscopic surgery to robotic surgery. It's a process. It's a drive. It's not a snap your fingers and it all changes. The second thing that I think is important to recognize about innovations is, first of all, it's a process, and secondly, it's risk-taking. If you change the established protocols, you are taking a risk. There has to be, you don't have all the evidence to say this is perfectly safe. You have a concept, you've researched it, but when you put it into practice, it might not work out quite as you expected. So there is a risk-taking element in innovation, and we have to accept that. This is an interesting chap called Joseph Engelberger. He said that if you have an innovation, for this innovation to thrive, you must know what your need is. So I say, I'm sick and tired of seeing people with a massive incision on their abdomen to remove their bladder. I think that these huge, full-length laparotomy incisions to do a cystectomy are unnecessary. There is a need to make these invasive operations less invasive. There's my need. How am I going to do this? I'm going to do this laparoscopically. The question you have to ask yourself is, yeah, okay, are you competent at doing this? Do you have the necessary skills to do this? And if you don't, how can you get them? And how can you say to people around you, yes, look at my evidence base of what I've done, and this means that I am now competent to do this. And then he said, you need financial support. Well, he clearly never worked in the NHS, had he? Because in the NHS, if you have an innovative idea, you have to finance it through the innovative idea. Your managers will always say to you, is this going to save us money? And of course it isn't. So you have to find some way, usually with a very inventive business case, to say that, yeah, this will eventually save you a lot of money. It's very interesting to hear what James had to say about evidence-based medicine, because what I could read about evidence-based medicine very much echoed some of his sentiments, and that it was originally an idea to collect evidence from high-quality randomized controlled trials and some observational studies, but also in combination with clinical expertise and the needs and wishes of patients. And I think that last line is the most important thing. You can't deny clinical expertise, and you cannot deny the needs and the wishes of the patients. So evidence-based is one thing, but you want to make it compatible with your surgeon who's in the room and the patient who's in the room. And there are articles now appearing saying that evidence-based medicine is heading into a crisis because the volume of evidence, especially clinical guidelines, look how many clinical guidelines and how many agencies came up to support the clinical guidelines, has just seriously become unmanageable. And the problem is, put your hands up in this room if you understand all the statistics in every article you read. Exactly. And the problem is, we're trying as individuals to read these articles when, let's be honest, we do not understand the intricacies of the statistics. So how can we apply them into what we do? We rely on the guidelines to say to us, this is statistically flawed. We still don't understand why it's flawed, but we have to accept that that is the case. And the problem is that in innovative changes, these small incremental improvements to gain statistical significance, as John Kelly said, to get evidence of the improvements in robotic cystectomy, you need a randomized trial of 1,000 cases. That is not going to happen. You cannot get big enough trials to prove statistically that things are improving. It's a question of looking at the small incremental improvements. And if you have guidelines and they're rigid, and some people do take guidelines and they bring them up in the MDT and they make them draconian. They say, you have to stick to these. And if they're driven like that, it's suddenly driven by management. It's driven by accountants. It's driven by bean counters. It's driven by non-clinical personnel, not really listening to expertise and patient needs. And James also said it, evidence-based guidelines often don't map very well to an individual patient with complex multi-comorbidities. They really don't. They just don't fit. And you have to use your intelligence to do that. And I was talking to Jeff Cadedo, who's a truly innovative surgeon in the United States, and his mother has I think it's a neuroblastoma. Now, the clinical evidence over the last 20 years is that if you have a neuroblastoma in your cranium, you will die. It has a 0 survival rate. Over 20 years, no one has survived. But new drugs and vaccines are being developed, and they insist on a randomized controlled trial. Why do you need a placebo-controlled arm in a disease where you know what the natural history is? It's nuts. It should not be allowed. I think in forcing a placebo control in a trial of a drug like that is unethical. I don't know why they do it. Which also brings me to the fact that surgical trials are really difficult to recruit to. Ask people who tried to recruit to laparoscopic pyeloplasty as opposed to open. You offered a patient the two choices, he just laughed. He said, I don't want to be randomized. I don't want to be randomized. I want the little holes. Thank you very much. And that is always, if you are offering something innovative, you will be telling the patient, we think it will be better, but we don't know. Patients will always come down and say, yeah, well, I'd like to try the one that's less holes. When we started to do lap cystectomies, the first patient looked me in the face and said, you want to experiment? You've never done this before. I said, no, I've watched the video and I've spoken to Indy Gill. He said, okay, I'll go for it. When we said we're going to move from laparoscopic to robotic prostates, the first patient said, can I be first? Can I be first? What is it with these people? They want these innovative treatments. They don't want to be randomized to the good old thing. So let's have a quick squiz at surgeons and what is our track record of obeying the evidence. And have we always listened to evidence as a group of surgeons, as a college? And have we accepted change somewhere where none was really necessary? Now, who recognizes anybody of these guys? Anybody in the audience? Let's pick a face that you really, really ought to know. That one. Who knows who that is? Lister. That's Lister. Anybody know who that is? It's Semmelweis. Anybody know who that is? That you should know. Fleming. That's Fleming. Very good. That one? Yeah, slightly old. That's Bill Roth. Okay, let's have a look at these guys. So Edward Jenner, 1796, noticed that milkmaids didn't get smallpox because they'd all had cowpox. So he went along to a cow, took some pox, got hold of a young lad, scratched his shoulder, put the pox on it, and lo and behold, he didn't get smallpox when the next epidemic came around. How many people have benefited from his work? How many people are inoculated in this world? Where is smallpox now? Where's polio now? All gone. Why? Inoculations. He started it. What did we say? Too revolutionary. You can't prove this. We don't want to know anything about it. What about Semmelweis? He noticed that in the midwives who delivered women, there was 2/3 less puerperal fever than in the doctors who were doing post-mortems, taking their hands on their coats and then going in to deliver the women of babies. And he wrote a book about it. And he was absolutely shunned. The doctor said, "You must be joking. Why do we have to wash our hands? Are you completely crazy?" It drove him mad. He was committed to an asylum. And there is a story about him that he actually then cut his finger to give himself an infection and prove that that's not true. He died of empyema because he was beaten up by the guards in the asylum. Theodore Billroth is a very interesting man. He is your modern NHS doctor. He started audit. He believed in publishing his results, both good and bad, so that people could analyze them. He did the first esophagectomy, the first laryngectomy, and famously, as we all learned to do the Billroth gastrectomy, he did the first gastrectomy. But what people don't know about old Billroth is that the first 3 patients he tried to do a gastrectomy on all died. And when he went home to his village, as he was walking home on the night after his 3rd death, he was stoned by the inhabitants of his village and was lucky to escape into his house without being seriously injured. The thing is, he was a great musician, and he said it's one of the superficialities of our time to see in science and art 2 opposites. Imagination is the mother of both. Remember, imagination is the mother of both, said by one of our better forebears. Joseph Lister, everybody knows, Listerine, infection, disinfectant, hand sprays and mist over the patient. His work was rejected by the College of Surgeons and Physicians. And this is a man for our own time, Thomas Kurt Sem, who was a German engineer and gynecologist. He introduced the automatic insufflator, loop knots, all sorts of innovations, and one day he added an appendectomy to a gynecological operation for ovarian cysts. And he was presenting his paper, and his projector was unplugged so that he couldn't present anymore. And I sat next to him in a meeting and asked him about this, and he said to me, "No, it's absolutely true. They said that this was, immoral to present this sort of thing." And his colleagues in his hospital made him go for a CT scan of his head because they said anybody who does laparoscopic surgery must be insane. You must have a mental defect. And but fortunately, his CT scan was normal. Barry Marshall. Remember Barry Marshall? He was the one who said H. pylori causes infections, causes gastritis and stomach ulcers. And in fact, to prove it, he actually drank a solution of H. pylori in his lab and gave himself a gastroscopy first and gave himself a gastroscopy afterwards to prove that he had now inoculated himself with this stuff. And it took ages before the established people said, you know what, antibiotics might be a better cure for stomach disease than gastrectomy. So we're not really that good at listening to evidence. Now, I'll be interested if anybody knows who Dr. John Romulus Brinkley was. He went to the appropriately named Eclectic Medical College in Kansas City. He didn't graduate, but he went on to practice medicine, and amongst his more illustrious patients was Rudolph Valentino and Buster Keaton. Does anybody know what he was famous for? No? Well, I'm not surprised. He was the goat gonad transplanter. He was sitting with a patient who said, "Do you have anything for sexual weakness?" He said, "Well, no, not really." And the guy looked out the window and saw a goat doing what goats do, and he said, "If I only had a pair of nuts like that." And he said to himself, "Well, I could give you some." And he did, and he set up a practice doing this. Of course, he got criticized. He was the first advertiser. He set up a huge radio station. He made so much money that he set up a radio station and advertised his services very widely. Of course, he got shut down eventually. He just moved across the border into Mexico, put up an even bigger aerial, and people crossed the border in droves. And he ended up, sadly, because of his frequency of operating while intoxicated and less sterile conditions, and of course putting goat gonads into people, there was lots of sepsis and patients died, and he got sued. But he did, on the way, make an absolute fortune. So, patients will go for something when there is no evidence base either, so we do have to be a little bit careful. And the interesting thing about, we all know Ralph Klayman and his 1991 laparoscopic nephrectomy, cautioned because of criticism of people doing, laparoscopic surgery and slightly way out cowboy stuff. Ralph didn't actually do that nephrectomy and publish an article in the Journal of Urology. He simply wrote a letter to the editor to keep it slightly low profile. Of course it was picked up and went, as we would now say, viral. But it was a 69-year-old woman with no family, and they did a 46-page consent document. He came to one of our meetings and told us about this whole thing. Absolutely fascinating how terrified they were of what was going to happen. And of course, as you all know, it took a long time, but the lady did very well, and of course her tumor turned out to be an oncocytoma. So, yes, there's need to regulate the surgeons. When we started to do lap cystectomies, we had to find out what it was, and we registered with something at that stage was called CERN, the Safety and Efficacy Register for New and Interventional Procedures. After the Bristol heart scandals, this was taken over by NICE in 2002, and it became IPAC, the Interventional Procedures Accreditation Committee. And really all you had to do was write to them and tell them that this was something innovative you wanted to do, why you thought you were accredited. And they then said, you collect all your data and send it to us regularly, and we'll say yes or no. And their advice was, go to a center that is, submitting data. And this has now grown into the Interventional Procedures Program. In Europe, they've started this thing called IDEAL, which is a stepwise innovation program. It's very detailed. It's highly investigative. If you have an innovative idea, you're not going to get it going in your hospital for at least 2 years if you follow all the steps in the stepwise innovation thing. The trouble with nice things is they're not really mandatory, and they rely on your cooperation and goodwill to submit your data to them, and it's based on you selecting, what data you send to them. And the problem is you're now these days often overridden by your local medical director, whether he thinks you're a good chap or not. And then each hospital now has an interventional procedures little committee which decides whether you can do it. And they all say you must have a mentor. Well, in 2002, Indy Gill had done 3 laparoscopic cystectomies. There were no mentors. You couldn't get a mentor for love or money. So every now and then you have to do things on your own. And I went to the surgical director who simply said, do you think you can do this? And I said, yeah, I'm pretty sure we can do this. I've got the skills. I've seen the video, talked to Indy Gill about it. And they just said, well, okay, go ahead and do 5 and let's see how they go. Unfortunately, they went very well. So it was a different era. And as we said before, doing things like this and innovating and building up your numbers, you're not going to get to statistical significance in a hurry. And so the only way you can prove that what you're doing is good is quality assurance protocols, so that you know that your blood loss is good, your hospital stay is less, etc., etc. And more in this day and age, you have to do patient-related outcome measures. Because what we think is important, like less blood loss and a short hospital stay, faster return to work, is not what patients think is important. They want to know, how does my pouch work? Will I be sexually potent? What are the side effects when you change the back? They have a completely different set of what they regard as important, and we have to measure that, because remember what we said? It's about what the patient wants and needs, not what we think is important. And my problem really about innovating these days is that guidelines really attempt to cover all eventualities, and when you bring them into the MDT, they become draconian, they become pretty prescriptive, clinical experience and patient wishes get overlooked. And when that happens, especially with some of the junior doctors, they get a bit nervous and they start to practice by rote. They want a checklist. They want to practice by rote so that they stick within all the guidelines. And that stops you having any original thinking. No imagination. As Bill Ross said, you must use your imagination and you must be creative. And you now put all of that in with a really litigious public, and what do? You get safety first medicine. And safety first medicine is bad medicine. It's stultifying. It leads to no laterality of thought, and it doesn't actually give you better patient outcomes. In fact, it does the other thing, because patients will come into an A&E, they'll come in with chest pain. What is the thing we're all terrified of when it's chest pain? That it's a heart attack. So you get the label around your neck, you've got a heart attack. And you go through all the investigations. In the meantime, your esophagitis is raging on, and you're not getting the correct treatment. So I'm worried about these draconian guidelines and think we need to think very carefully about how we put them into practice. So I'll go back and just say that innovation means taking risks, that all innovations must be patient-centered, that your patient must be given all the information he needs to make an intelligent decision about the options you're offering, including what is standard, what your innovation is, and how you think it's going to improve his outcomes. I think you do need to collect your data prospectively and carefully and honestly, and you need to review it on a regular basis, and you should be part of some quality assurance protocols. And it's the surgeon with a lack of insight into what he's doing is wrong is the dangerous one. And that is why your data collection must be open, it must be above board, it must be shared with your colleagues so that they can come to you and say, you know what, you've got a problem. Have you noticed that you're getting a lot of strictures of your left ureter and amongst your ileal conduits? And why is that happening? How can we help you improve that? Because if you don't review your data, you're not going to see it happening. Your mistakes are going to carry on for too long. And the final slide is the only thing that's constant in life is change. Who is it? David Williams with his famous show where the computer says no. The NHS natural reflex is to say, no, we don't change. No, that's not the way we do it. No, we write 27 letters to get a TURP done. That's the way we've always done it. No, well, you can't change. Everything has to change. We have to make ourselves open to change. And you must remember that there's nothing more difficult than to take the lead in the introduction of a new order of things, because the innovator has for enemies all those who have done well under the old conditions. Thank you very much.